Big news! Wayfair's tax refund sale is on now. Right now through March 2nd, you can score up to 70% off furniture, decor, appliances, rugs, and more. With fast and easy shipping straight to your door. Plus, amazing flash deals. Shop Wayfair's tax refund sale now to make the most of your refund with huge savings through March 2nd at wayfair.com.
Wayfair, every style, every home.
A quick trigger warning, there is some brief mention in this episode of trans healthcare bans and subsequent increase in suicide rates. You can find timestamps in the show notes.
Beyond cis male, cis female, non-binary, trans male, there are more.
They're swimming in like the gender soup
of different experiences.
Gender is like a marker of time, thinking critically about what inclusion means.
So much of womanhood is tied to whiteness, is tied to thinness.
How do I identify myself? Faggot.
Non-binary.
As femme as humanly possible.
I'm a cisgender gay man.
A binary trans woman.
Theatrical and flamboyant. Dykes who identify as twinks.
A gender conscientious objector.
I just kind of forget that I have a body.
Drag helped me unlock the power of my femininity within a masculine persona.
Transitioning when you're older,
it opens up an entire world of possibilities.
I bloomed, I blossomed.
Comfortable in my physical body for the first time in my whole life.
Existing
in a more nuanced way.
In thought, in imagination, in fantasy.
My gender in my head feels like the cosmos. Just fully unknowable, even to myself.
I wasn't trying to be a gender. I wasn't trying to be a race. I was trying to be a point of energy in the universe.
That's amazing.
I love that.
Babette, I don't know if you noticed, but I'm wearing a collared shirt today and kind of like a sweater.
Okay, I did notice. You look very nice.
Oh my God, thank you. Well, I was thinking about you and, I just think it's really cool that you're a PhD student.
You think so?
Yeah.
You look very collegiate.
That's what I was trying to do. I was trying to look Ivy League-ish.
Yes, it's giving.
I'm actually going to become a doctor.
Wait, really?
No. But I did. Okay, so today's episode, I talk to a doctor.
Okay, so you just fucking lied to me. Sick. That's cool.
I wanted to do some research. I've been on T for 2 years, but I still had so many questions about HRT, how it works, the different ways it's prescribed, basically what all the options are. I know what my experience is, but I'm curious about yours. I know on the show you've talked a lot about testosterone. It didn't work for you. You didn't like how it made you feel. Is that still where you're at? What's your relationship to it?
That is still where I'm at. I think a lot about embodiment and bodily sensations because I have pretty bad anxiety that I'm well medicated for. And so I just don't really feeling different. And I felt whenever I would take tea, in my gut, I would feel very different. I would feel kind of more impulsive, obviously hornier, but I kind of also felt more irritable. And I just felt it took me away from my homeostasis that I worked so hard to maintain. And granted, if I stick with it, I'd probably be fine. But then I also realized, I think I just wanted a little bottom growth and a little mustache. And I didn't really want anything kind of beyond that because I'm oh, fuck. When you have facial hair, you have to fucking shave. And I'm oh, I don't want to do that. I'm actually too pretty to do that. I'm so sorry. I can't do that. So...
Well, some people take TUC for over 2 years and they never get a mustache. And it's actually pretty unfair to them because they're actually a pretty good person and they didn't deserve that. And their brother has more facial hair than anyone has ever seen in their life. So
are you
riddle me that?
I was just going to ask about your dad and your brother. That's crazy. Because you just know before you started T, you were oh, sick. My brother has facial hair. I'm going to look just like him, know?
Exactly.
Yeah, the thing with hormones is you literally just do not know what you're going to get. And you just don't get to choose, really, which I think is maybe the thing that holds me back. And the reason I only take tea maybe once every 3 months when I'm just feeling a little spicy after a shower or something, because I just can't commit to everything.
Yeah. Okay. There were so many things about tea I didn't know. So this was a super helpful episode. I feel selfishly for myself, just hearing all the ins and outs of hormone replacement therapy and its function in the medical landscape right now. this doctor that we talked to had a lot to say about that, which was so great. And it was just cool to talk to someone so radical. I feel like they were a very interesting person. And I wanted to get really academic about this and do some research, talk to this expert. And so I kind of want to present my findings to you dissertation defense style, and you can peer review them. Does that sound good?
My God. Okay. I'm so into it. I can't wait to hear what you found out.
Oh, you just put on tiny little glasses. Where did you get
They actually just like appeared. Yeah,
yeah.
Exactly. I can't wait to hear your findings, Dr. Beardsley.
Oh, Dr. Beardsley, that has a ring to it.
Mm-hmm.
Okay, everybody. Here is Dr. Crystal Beal.
My name's Crystal Beal. I'm a family medicine physician by training, so I'm board certified in family medicine. I use they, them pronouns, but I spelled them a little different because I would probably use neopronouns if it wasn't exhausting to get everyone on the same page. And people sometimes ask about the spelling or like where it came from, and I'm like, bitch, I made it up. I don't know.
Yeah.
You can just make this shit up. I don't know if you knew that. But
for the listeners at home, it's a THEMME. I love that.
And if anyone's not watching, I'm like femme as fuck. So I started focusing my practice on gender affirming care in about 2018, which is when I opened a practice called Career Doc. It's a telemedicine practice focusing on trans medical care, open in 10 states. So really all I do all day long is puberty blockers and hormones and other medications associated with supporting gender goals in medicine.
How did you get into medicine?
I was in my 5th year of undergrad. I was actually about to finish a degree in like dietetics and nutrition and realized how much they were going to pay me. And was like, oh, maybe I should try to go to medical school. And also kind of felt like future me might wonder if past me could have gone to medical school. And so I was like, oh, maybe I'll just like try to answer that question. Then I kind of like thought maybe that was a poor life choice for the next several years.
Wait, why?
It was really meaningful to be doing something that felt meaningful. So I think that was good. But medical training is like pretty dehumanizing. It's really ableist. It's really like cis and heteronormative. I mean, like the whole world is, but I think medicine is that in an amplified way.
Wow.
So I think I was kind of like, what did I gave up the best years of my life for this. But then I started working with my own community and I was like, oh, okay, this is worth it. This is great. And I do a lot of, we don't do them as often anymore because with the federal changes to self-attesting gender markers on passport and Social Security, people need letters from providers less often for legal transition. But I used to do like legal transition clinics with some of our like local grassroots nonprofits, and it's the best use of a medical license in the world.
Totally. I definitely had to go through that. I feel like it just recently switched, and I just remember I'm at the DMV with a letter from my therapist. This is crazy.
Yeah. Once I started working with my own community, that was great. I do a lot of activism and a lot of advocacy on my own small business. So all of that's sorting itself out, but I love what I do and I love working with my own community. It's super rewarding. Makes the medical degree feel mostly worth it.
Totally. Oh my gosh. It's so cool because we've been looking for someone to have on the podcast that does work with hormones, and it's really hard. I feel like because it's such a fraught thing in the news to find someone who wanted to come on and talk about hormones, because I feel like it just gets thrust onto what other doctors are doing, and they're just kind of like, here's this random thing you've asked me to handle. Like, it's not like specialized in this way that it seems like you do, and that's like really, really cool.
Yeah. And a lot of doctors who do maybe do it in higher volume are often employed at large systems who won't let them speak publicly, or they're afraid they can't speak publicly. That happens as well. And then, yes, with the political situation really shifted tone in like 2022. I've had death threats. Some of my colleagues have had like significantly severe and like more scary ones than I've had. And so that definitely, I think, dampened people's willingness to talk about this.
Totally.
Like, we're currently facing the genocide of a generation of trans adolescents. We have 26 states with bans on best practice medical care, on life-saving, medically necessary, evidence-based, gender-affirming care. And we just had a publication come out in Nature just within the past 6 weeks, maybe, that shows causation in increased suicide attempts because of healthcare bans. I think sometimes my colleagues, I'm frustrated with the unwillingness to speak up, because I think all the time for me, like, what would it have meant for me as this super queer, odd little kid growing up in a super religious house in the South? What would it have meant for me to have seen a physician like me as my healthcare provider?
Totally.
It would have been life-changing.
Yeah.
I know it's scary and everyone needs to make the decisions they need to make to feel safe and feel sustainable. And for every person, that's going to be different. And this is fascism, and it does not go away when we are silent. Our silence means that probably one more trans kid is going to die because they didn't hear from a trusted adult that we love who you are. We're here to help support who you are. And I'm going to be available no matter what the law says, no matter what happens. You matter.
Yeah. I don't know. I'm just having like a spiral of my own where it's so crazy that this side of the political landscape that's all about freedom of speech is like, you can't say that to my kid, or, you know, like my kid only needs to hear what I would tell them. And it seems like this like really crazy cultural touch point right now is specifically this think of the children, protect the children, coming from that side of things where, yeah, now we're really seeing that it's causing death, it's causing depression, anxiety, etc.
Yeah. It is hard sometimes to find clinicians who can speak up or who are willing to speak up. And I think it's essential for us to speak up. It's so important for clinicians in the field to talk about their work with their friends and their family. The people who like might not know someone or know that they know someone who is trans. If it's like your friend who is a doctor is like, this is what I do and it's awesome. And like, I get to watch these kids blossom and become who they are and succeed in life. One of my 17-year-olds is learning how to do nails and skin right now. You know, one of my 19-year-olds is in computer science at university, and they're just becoming who they are. And it's so fun to watch. And if we talk about that with our regular upper middle class white friends who maybe like don't get a connection to queer and trans community, and the ways that we do, that can be impactful because the misinformation and malinformation and disinformation, it's confusing a lot of people.
Yeah, totally. I'm really interested in Queer Doc. I didn't realize that it was specifically for gender affirming care, gender questions. How do people reach out to you, or how does this whole thing work? Do you have recurring clients?
Yes, yeah. So it's just like an online doctor. You know, it's like if you've seen Folks or Plume, it's like, yes. Just to be a little snarky, we were there first. It's kind of more like a small private practice pushed online versus a venture capital backed telehealth startup. Let me also be clear, even though I'm being snarky, the more options that trans people have, the better. So we're happy to have Folks and Plume around. I guess maybe the slight difference, our focus is maybe a little more individualized, like nuanced care out of practice, because I think with Folks in Plume, it's a little bit faster, the turnover, the appointment time. I've never been a patient there, just from what I've heard people say.
I actually went through Folks to first get testosterone. So I had that experience of the online intake kind of thing, because it just felt a little bit easier for me to navigate than trying to figure out local healthcare, go in person, worried about who you're going to have to talk to. But yeah, ultimately it ended up being a little bit cheaper to not keep going through their subscription program.
Okay, I have like 17,000 things to say about this. I think trans healthcare should be accessible in every way, shape, and form. Actually, frankly, I think that DEA should be abolished and all gender-affirming care medications to be available over the counter, which would have some complexity around insurance reimbursement, and I understand and recognize that as well, but insurance really only helps you if you have insurance. So I also think we should have a single-payer system that supports over-the-counter gender-affirming care medications. So we don't have that currently. While we don't have that, I do think gender-affirming care, like you should be able to get at your primary care provider's office. You should be able to get it at Planned Parenthood. You should be able to get it through telemedicine. You should be able to get it at the OBGYNs. Like you should be able to get it at the endocrinologist. There should be people who specialize in it. There should also be people who do it for like 5 people a few times a month. I think all of the options are essential in the current system that we have. And there's a huge threat to telemedicine access to gender-affirming care rolling around at the end of December. I don't know if you're aware of this. Okay. So if we want to ask any of your listeners to do some like calling of their senators and legislators, or writing some letters. The thing that allowed you to go through folks and allows our patients to do that with us is these prescribing flexibilities around controlled substances. So testosterone is a controlled substance in the United States. And there's a law that passed several years ago that says to get a controlled substance, you have to see someone in person at least once for them to be able to prescribe it. That requirement was lifted during COVID. And the telemedicine flexibilities that have existed are set to expire December 31st of this year.
Wow.
Unless the DEA extends it again or comes up with a different solution. And this is really important. Solidarity is essential. And so this is really important, not just for trans people taking testosterone, but also for people like who are neurodivergent and need stimulants. Those are also a controlled substance. Or people with a substance use recovery using buprenorphine. That is also a controlled substance. So there are a lot of medications that support a lot of people that people will struggle to get access to again. Wow. When we look at data in trans and gender diverse populations, they're twice as likely to access healthcare through telehealth as their cis peers. And that's because when 2 out of 3 primary care providers and 3 out of 4 endocrinologists report that they don't feel competent doing trans healthcare. Prior to COVID, trans and gender diverse people were like 5 to 6 times more likely to have to drive more than 50 miles to access care for gender care versus only having to drive 10 miles or less for primary care. And we have seen in all systemically undervalued populations that accessing healthcare through telehealth, we do it at higher rates than our cis peers. Just to like get on my tablet or my phone or open my laptop and know that like the chance of you physically assaulting me or me getting physically assaulted on the way to your office or me not being able to piss on the way to your office, none of those problems are going to happen, right? And if you're an asshole, I can just turn the camera off.
Yeah, totally.
I think that's huge.
And you're in your home base. There's security there. Yeah, totally.
Yeah. Okay.
Wow.
I think I'm off my soapbox about it. But call your legislators, ask them to lean on the DEA to extend the telemedicine prescribing flexibilities.
That's so interesting that it's going away. I know so many people who transitioned during COVID. That was like a really big time for people transitioning. Did you notice that in your practice?
Oh, yeah. Yeah. And I think the whole, like, I don't have to do like second puberty in front of my workplace or my friend, you know, I just get to do it with my dog and my plants.
Very alluring.
Yeah, for sure.
Also, I had a question when you were talking about controlled substances. Is estrogen also a controlled substance?
No, just testosterone.
What? Why?
Yeah. Toby Beauchamp, I think, wrote the article on the original situation about how testosterone became a controlled substance. It was related to using it for improvement in sports performance.
Interesting.
But initially, the DEA opposed including it on the controlled substance list. And so Toby like really looks at the misogynistic and transphobic roots of that in a great article that I can send you the link to.
Oh my gosh. Yeah, we'll link it in the show notes for sure. That sounds so interesting.
But generally, let's be clear. Also, the DEA is an organization that's roots are in the war on drugs. So it's like rooted in racism and creating a pipeline to prison-based incarceral slavery for Black and brown people. Also, it has never actually helped reduce substance use. Right? Totally. So the thing it's supposed to be doing to help people, it has not successfully done. We have research and statistics saying that.
Yeah.
So yes, we should ask them just to like extend the flexibilities, but also maybe ask your legislators to vote to abolish the DEA as well.
Ooh, oh, wow. Wow. We love. Can you walk us through how hormone replacement therapy works or the basics of it going in different directions?
Yes. So I'm going to focus on adult care
just
because that's, I feel like, an easier place to start. Most of gender affirming care or trans medical care is moving towards, if it is not already there, an informed consent model of care. So historically, people used to have to go to a therapist and get the therapist to write them a letter of support saying they were trans enough to get hormones.
Yep.
Okay, we don't have time to do it on this episode of the podcast, but like if we ever want to talk about the history of how shitty trans healthcare has been, we can do that too, because People used to have to leave their families because you cannot be a trans woman and a father. That's not a choice you can actually make.
Wow.
So people like historically used to have to leave their children, leave their partners, who have to live in their chosen gender for a period of time. They had to prove that this was the thing that was right for them. The field has come a long way and is moving away from that. Letters are no longer recommended for hormonal care in WPATH, and most clinicians don't require them in most situations. So informed consent means that a patient has the capacity to understand all the potential treatment options, including non-treatment, the risk and benefits of those, and the impact they might have and the meaning they might have in their own individual life, and then communicate which one they would like to try. So typically, most people 18 plus can see medical providers that do informed consent models of care and usually have a medical appointment where they get to talk to their provider about their gender and their goals for their body. And then again, if they have that informed consent model and the patient demonstrates capacity, they're typically able to possibly do blood work and then get a prescription. If they're otherwise healthy and don't have a lot of other significant health concerns, sometimes like they can opt out of blood work. And then as a medical person, I'm super focused on like, what do you want different in your body? What are the goals? Do you want boobs? Do you not want boobs? Do you want erections? Do you not want erections? Do you want facial hair? Do you not want facial hair? What do you want happening with your voice? Like, so I'm really like objectively goal-oriented in my work with people. At our clinic, we have pre-visit paperwork that people do, and then we do have this hour-long intake. So it is not like you spend 5 minutes with me and I'm like, have your candy. That's what the Republicans are saying. That is, but let me be clear also, if you're a fucking adult, fucking go for it. You get tattoos.
If you could go and enlist to fight
you can enlist,
in war.
You can drink, you can get a tattoo. You can buy nicotine and like tobacco products. And I think that's one of the other misconceptions about hormonal care and gender affirming care is that if you start hormones, like everything's going to change immediately overnight. That is also not true. This is second puberty. It maybe goes a tiny bit faster than the first one, but we're still talking about a multiple year process. So you can actually start on a low dose of testosterone or estrogen and not have a ton of physical changes for like a handful of months, but like have a little better sense of how it feels in your brain. And is it feeling good for your brain? Is it not feeling good for your brain?
Yeah.
That is how we do the rest of fucking medicine. We take medicines and we try and see how they work for an individual. We don't say, oh my God, you absolutely have to know exactly which antidepressant you want out of these 15.
Yes.
And you have to be convinced that you're not going to regret it.
Totally. Yeah.
To be fair, I took antibiotics for my acne in 2018 and have regretted it for the rest of my life because my poops have never been the same. And no one made me
And where was the right then?
Right? Right? Where were the Republicans then? Why did they not protect my pooping? My God.
Oh my God. It's also crazy that they're like, you haven't spent enough time thinking about this, or no one goes to like a consultation with a doctor having not done any research or having not mulled over this question. I feel, or at least nobody that I know. That's not like my first stop. There's all of the internet. There's all of YouTube. There's all of like zines and all of this information you've probably been ingesting for a long time. Now you're taking the step to go talk to a doctor.
There's actually some research, particularly there was some qualitative research around people seeking gender affirming surgeries that shows absolutely most trans and gender diverse people do a fair amount of research on their own before they ever see a surgeon.
Okay, so that's how hormones get prescribed. I love that you brought up low dose. I feel like that's something that is like a really gentle entryway. And like, I love that reframe of you don't start a medication and if it didn't work, you were completely wrong about yourself and there should be a lot of shame. Like it's a trial and error. How do people go about getting, say, like estrogen or testosterone? Or I know estrogen also has progesterone that you take with it, or
sometimes, yeah.
Okay.
Yeah. Okay. Also, I feel like I want to be clear for people who are like, well, that doctor on the podcast said I could just like go to this one appointment and walk out with hormones. That is how it should happen most of the time. And the ideal care is not available everywhere.
Totally. Great.
So just disclaimer. What was your question? Oh my God.
Testosterone or estrogen, like what are kind of those pathway? What does it look like to start taking those?
Yeah. Like what happens in your body? Like what does it feel like?
I guess, yeah. What are the options for someone who's like looking at either of these things? I love low dose as like an option.
Okay. Right. I have patients who come to me who like maybe want their voice different and really, really want top surgery, but are like not super convinced they're like going to be stoked on facial and body hair. And let me be clear, you're going to be hairier all over forever as long as you take testosterone. Like patients all the time are like, no one told me about the butt crack hair. And I'm like, you had a shit doctor because there's going to be butt crack hair. It's going to come out your nose. It's going to come out your ears.
Yeah,
it's
totally.
Like hair. And someone who had those goals, like I would want to make sure that they know there's like an option to do voice training or voice work or even consider a voice surgery and top surgery. And you don't have to take testosterone to do those things. You can achieve those goals without testosterone. Or maybe it's like they want voice stuff and top surgery and they really hate their periods. There's still options that don't involve testosterone to stop periods.
Yeah, totally.
So it really is this whole picture of how do you feel about all of these things that would happen with this? I also like to be really clear when I'm working with patients. Sometimes I'll be like, are there any side effects you're worried about? And they're like, no, I'm fine with all of them. And I'm like, it's okay if there's some you aren't worried about. It doesn't mean I'm not going to write you a prescription.
Yeah.
It means like I might also have other suggestions for like another intervention that might minimize that side effect or decrease the chance of it, or like some skills for you to use to cope with it. Again, it's like when I'm thinking about what is the pathway and what are the options and then how do we approach it, I'm thinking about this holistic picture of someone's individual goals. And then I'm trying to give them all of the options so that they can then listen and pick the ones that they want.
That's so cool that you can kind of a la carte it.
Yeah.
You can start with what you want and get like specific about that, which is really fun.
Yeah, we try really hard. There's some limitations in like what we can do, but I still need to have the working framework of that to help you understand the path forward. So all of those other things aside, like voice work, gender expression work, like binders and packers and makeup. And like, I think a lot of times people think about makeup only for femme presenting folks, but like you can use makeup to mask up as well. All of those things aside, when we are starting to talk about testosterone typically comes in injections, in gel you put on your skin. There's also capsules. They only got approval.
I was going to ask, I was like, why isn't there a testosterone pill?
There is. It got FDA approval in 2019. So there's still no generic. So it's harder to get covered and it's much more expensive.
Wow.
And then you also can't titrate it as easily because like no one's been using it in gender care. So we don't know how equivalent it is and all of those kinds of things. And so you can't cut it or break it. So it only comes in certain strengths.
Wow.
And then there's also a nasal gel that you can put in your nose.
What? Like a Flonase kind of?
Yeah, but it's like a little gel. It's a little thicker.
Oh
yeah.
Gosh, that sounds so unpleasant.
Yeah.
Because sometimes it smells crazy. Like, I don't know if you've interacted with it, but if it seeps out of like an injection site, sometimes I'm like, what is that smell? And I'm like, oh my God, it's testosterone. Why am I putting this in my body?
Yeah. And so most commonly used in gender affirming care for trans folks is injections and gel on your skin.
Mm-hmm.
For people who are interested in like changing their body as much as possible with testosterone, a lot of times if we're talking about injections, they're eventually going to end up on somewhere between 60 to 100 milligrams injected once a week. Historically, they used to do injections every 2 weeks. That was because they were looking at how it was used in cis men. And the reality is the dose doesn't last a full 2 weeks. It starts to taper off around day 10. So if you try to go 2 weeks, you're going to feel pretty crappy for a few days. And so we definitely have shortened that.
Wow.
Once a week, typically.
Yeah.
Here's the thing about testosterone. If you take too much of it, your body turns it back into estrogen. So sometimes people are like worried that trans people are going to like go wild and take like too much of their hormones or whatever. And let me be clear. I always tell my patients, look, once you get the medicine in your hand, it's your own fucking body and you can do whatever you want with it. So no harm, no foul. You get to decide what you put in your body. I don't decide that for you. But the reality is taking too much of it is actually going to counteract some of what you're trying to do. Because there's an enzyme that does that. So you'd have to take a medication to block that enzyme too.
Oh my gosh.
And then like the way hormones work in our body is they only work when they can get into the receptor and the receptor lets them into the cell. So at some point you like really saturated all your receptors and then you just have extra hormone running around your body, not really doing anything, but costing you money and maybe causing you some side effects. So our patients, we typically like work our way up to that 60 to 100 over anywhere from like a few weeks to several months, depending on like their goals, their pacing, their timeline, their values, their risk tolerance, their pre-existing health. I tend to be more of a like lower starting dose and gentler titration upwards kind of clinician. But I also work with a lot of adolescents. So tiny amounts, tiny, like a whiff. We'll just give you a whiff. I think also like it's a big shift on your brain. Because if you look at the guidelines, they'll sometimes say you can start anywhere from 40 to 80 milligrams a week, which I just told you is like basically maintenance dosing. If someone decides that's what they need to do and what feels right for them, I'm going to say, okay. My thought is that's like a really big hormonal shift for your brain really suddenly.
Yeah.
And especially since a lot of us have neurodivergence as well, especially if we have any ADD or any impulse like control issues, it might be a little easier for our brain to like adjust a little bit more slowly and make sure we have like the coping strategies we need for any kind of testosterone doesn't really tend to make people angry, but they can feel a little more irritable or impatient.
Yeah, totally.
And so just making sure like we have coping strategies we want to use for that.
I've heard that from some people. It mellowed me the fuck out. It really rounded the edges in this kind of crazy way that I'm like, oh yeah, that's really interesting to know. I've heard from some people that they go to gel first for like a kind of like micro dose. Is that seem common, or do you mostly just prescribe it for people who don't want to inject?
I feel like I always ask people, it comes in these forms. Is there one you were more interested in? I think you can low dose or micro dose either option, because you can inject 10 milligrams of testosterone a week and like you're not going to see a lot of physical changes. If anything, you'll be like sweatier and oilier. And your voice, even if you can't see it or feel it, your vocal cords are affected as well.
Yeah.
You won't necessarily get like a lot more facial hair or body hair. You won't have like huge voice changes, especially if you're not like a trained voice user. No, but you get a little mental, emotional impact from that. So I think you can do really low doses even with injections. And then you can actually get like just as high of levels with gel. I think like part of the secret that people don't realize is you need to spread that shit real far and real thin. So like the part that's getting absorbed is the part that's touching your skin. So if you've caked on like a half-inch layer of gel, it's not going in. It's just sitting on top of itself.
The shirt is soaking that right up in the half hour afterwards that you put it on. Yeah, totally.
I tend to, there's like off-label, do not come after me, people who come after doctors on the internet. I just tell my patients to put it on their upper legs. Because you tend to have a lot more surface area. Yeah, and so you can actually get, even with just like 3 pumps, like 2 to 3 pumps, you can get like into that adult cis male testosterone level range.
Wow.
So gel can do it, but everyone's body is different. Some people's bodies absorb it better than others. And definitely I use gel for people who are like interested in avoiding injections. And sometimes people do come because they're like, I do want to like try something slower or gentler. Again, I think you can still do that with injections.
And with estrogen, is it a similar thing, but you're breaking the pill up, or how does...
There's pills, there's injections, there's patches, and there's gel.
Oh my gosh. Wow.
Yeah. And most people start on pills. Some people come asking for injections. Pills of estrogen are like the cheapest, most affordable form of estrogen. So for people who don't have insurance coverage or have restrictions on funding, like that's going to be the most accessible format. The research shows that patches, tablets, and injections are like equivalent.
Cool.
Community wisdom sometimes says people kind of say like, I think injections work a little better. And here's the reality. Everybody's body is different. Like if you try to give a pill to someone who has an inflammatory bowel condition, they're probably not going to get as good of absorption.
Wow.
The injections, the caveat is that they do sometimes go on national shortage. This sometimes happens with testosterone as well, but it's seemingly a little bit worse with estrogen. Yeah, there's 2 types of injectable estrogen available in the United States, and one of them has been on back order since like October of last year.
Wow.
And same, definitely have patients come to me who are like, hey, I'm not sure I want boobs, but I would like to see how I feel on estrogen because for many years I've been thinking something's going on. Right? And I'm like, okay, let's try that.
Great.
And so we might try like as low as 0.5 milligram of estrogen every day that they take and see what they think about that. And typically in most people, again, that's not going to cause breast development, especially if you're not also taking a testosterone blocking medication or an anti-androgen. The caveat is occasionally people with differences in sex development or intersex conditions might start something. And if they already have something in their body that makes their testosterone not work as well, they might see changes much faster.
Yeah, totally.
Which is also true when we're talking about some people who are interested in testosterone already have higher levels of testosterone in their own body. And so definitely, like, I feel like people with like slightly higher androgen producing content already a lot of times get like upper lip hair much faster than I would typically see.
Yeah,
yes,
totally.
it's like next week. I'm like, what? Great.
Now, I have a question for you, and I understand if you're not able to answer it, but I feel like I have a lot of friends who don't take their hormones regularly. Maybe they're kind of on the fence. Maybe they want to do like a cleanse off of them for a while and then go back on. Is there a drawback to that? Is your body having a hard time if you do like a pump of testosterone this day and then you don't do it for like a couple weeks and then another one? Or
Yeah. I have some patients who are like gender fluid in a way that like some days they want to take their hormones and some days they don't. And the reality is we don't actually know exactly what that means for bodies. Mostly like what we think about in the context of hormones and hormone deficiency and things like that is really rooted in long-term aging. So we know bodies need a certain amount of sex steroid hormones, whether it's testosterone or estrogen, to like optimally age over time and to reduce your risk of cardiovascular disease, dementia, and osteoporosis.
Wow. Yeah.
When I have patients who want to like take long-term super low doses of things, or are maybe interested in blockers only, or maybe are going to be doing this some days on, some days off, I want informing them that I can't fully counsel them on all of the risk. So like I want them to be okay with that information. And then that I think we should do things like screen for cardiovascular disease and osteoporosis and stuff maybe a little sooner. Like maybe we're going to check your cholesterol sooner. Maybe we're going to think about doing like a calcium scan for cardiac health, or maybe we're going to think about doing a bone scan for bone mineral density. So things like that.
Yeah, totally.
So working with like a preventive care primary care provider who can help facilitate those things. In the short term, hormones affect your brain and emotional status pretty significantly. So besides those big shifts, we don't know about significant short-term risk in that. I want to be really clear, what you're talking about is incredibly different than forcibly stopping trans people's hormones because of state
like
sanctioned.
If you hear that you can no longer have hormones, totally different.
Right. Yeah.
I have another question about finasteride and these kind of like supplemental things that people can take. Can you tell me about that? I was a little bit confused when I first started, because I feel like a lot of people, my number one fear was, oh my gosh, what if I go bald? My dad is bald. You kind of pick one thing to decide you're not going to do it at all. And that was kind of like the one thing I think my fear latched onto. I was told that when you're first starting to take testosterone, you maybe don't need to take finasteride or something because it's literally blocking some of the hormones. So maybe later on you can add that. Is that something you would agree with?
Well, one, I love that you're like, I had this one thing I was afraid of. I think one of the things like I love that I learned in hospice care is like when we're thinking about end of life, sometimes we think about someone we love, whether it's a human or a pet, being with us, and we're like, but they're still doing this one thing. They're still eating, or they're still bringing me their toy, or they're still wagging their tail, or they're still getting out of bed and coming to the living room to talk to me, whatever those things are. In hospice care, we really talk about making a list of 10 to 20 quality of life things. And when we get down to only doing 3 of those, really starting to think about, is that the quality we wanted?
Interesting.
And so if I think about that in reverse, I had this one thing I was afraid of. One, always go to a knowledgeable clinician and talk to them about that one thing to really understand it. Here's what I say about hair loss. First of all, it's inherited actually through the birthing parent side of your family. It's X-linked. It's not your non-birthing parent or your dad that is as important as on the birthing parent side of your family. And then we have about 12 months after a hair falls out to try to revive it. So when a hair falls out of the follicle apoptosis dies in about a 12 to 18 month time frame. So hair loss is not permanent until it's been lost for 12 months. So when there's a window of time where you can try tea, even if you're starting to lose some hair, where your hair will regrow if you stop it. And then 2, There's a lot of medical interventions we try to reduce head hair loss, slow head hair loss, or preserve it over time. I don't think any of them are 100% stopping it in its tracks. We are slowing a thing that's going to continue to progress over time. But I tend to use a lot of low-dose oral minoxidil, which is a medication that causes increased blood flow to hair follicles. And so it doesn't interfere. Finasteride is a 5-alpha reductase inhibitor. So it decreases the conversion of testosterone to 5-dihydrotestosterone, which is the more active form of testosterone that is also very active in hair follicles.
Is this something that you would get injections along your hairline
This
with?
is a pill you take. It's also available over the counter as Rogaine.
Oh, wow. Yeah. Interesting. Wow. Cool.
In patients who want to take testosterone and are worried about hair, I use a lot more low-dose oral minoxidil than I do testosterone blocking medications. Just because we don't want to block the testosterone, we want to feel how that feels. There's like laser light therapy that can help as well. There's derma rolling with like little needle rollers that can help.
Oh, yeah.
Yeah, all that can help. If people have like, I overflex my eyebrows or my eyebrows are thinner, I want like mad bushy butch eyebrows. I actually absolutely use the generic version of Latisse, which is a word I can never say correctly.
Yeah.
It's like Prost, something like this.
For eyebrows that you
for eyebrows. Yeah.
Wow, I love that. And you can kind of choose where it's growing.
Yeah.
Oh, cool.
Yeah.
I love.
Sometimes we still use testosterone blocking medications in people taking testosterone. I tend to look at ways to minimize the impact on the testosterone effects. So like I tend to try to find other options or talk about like doing it as a solution on the scalp as opposed to a pill you swallow. That's my approach. But again, my general approach is to tell someone these are all of the options. Which one sounds most interesting to you?
Yeah. I kind of want to veer into the world of adolescent hormones. It feels like there's such a misunderstanding where people are like, they're pumping this 7-year-old full of hormones. The most you're going to do is a puberty blocker, and that's closer to puberty, right?
Yeah. So it would be pretty exceptional for a 7-year-old to be in puberty. It does happen sometimes.
Yeah, true.
Yeah. There's a thing called precocious puberty, but you would be treating precocious puberty, not transness at that point. The average onset for puberty for people with ovaries is 10.5 and people with testicles is 11.5. And so it's not common for young people, for youth or adolescents to need medical interventions for their gender care until closer to that age. And then, yes, we do not start a medical intervention typically until their body has started puberty. So we have medical evidence supporting this onset of puberty. And then, yes, when they're that early on in puberty, typically what we're doing is a puberty blocking medication, not hormones. Typically.
Yeah. Not pumping their little body full of hormones.
No.
It's like, oh my gosh, the rhetoric is insane.
And even when we do start hormones in adolescence, what we're trying to typically do is replicate what puberty would have been like if they had the gonads that are better fit for them. So that is small increases of hormones over time. It's like, again, typically in adult care, sometimes they'll talk about trying to shrink second puberty into like a 2-year process. I'm not doing that with an adolescent. I'm giving them a full 4 to 6 year puberty like they would have had on their own.
Totally.
They just don't have to do it twice anymore.
Yeah.
And they don't have to have changes in their body that stress them out and that they might have to have surgery for in the future.
Totally. If someone was looking to get on HRT right now, what would you recommend? I'm sure this varies state by state, but what kind of path would you recommend?
Yeah, absolutely varies state by state. Do you have health insurance? Do you not have health insurance? Do you have a primary care provider? Do you not have a primary care provider? Do you trust your primary care provider? Do you not trust your primary care provider? So I, same as you, think like the best place to go is the World Wide Web. Well, one, it's your friends in your local community. If you have friends in your local community who are accessing gender affirming care, you can ask them what they did, where they got it, because that will give you maybe potentially more local information. Also on the internet, you can look for your local LGBTQ nonprofit for whatever region you're in. Centerlink is an organization that keeps all of the larger LGBTQ nonprofit organizations and community centers. You can find them in every state at Centerlink. There's also smaller like grassroots organizing, right? And trans community organizations that you might be able to find as well in like your local zines or posters or queer coffee shop where all the baristas have piercings and tattoos. So all of those things. And then also trans people love Reddit and Discord servers so much. So asking on Reddit and Discord where people have done it, what worked for them. You can also go to your primary care provider if you have a primary care provider and you have insurance and you feel safe asking them, and ask them if they do it or if they know someone that they can refer you to. And then there's a few different provider directories available as well. And so we link all of them on our clinic website. So we have a webpage that's like a virtual resources page, which links directories to find providers around the country and also links all the other online clinics available as well.
Whoa.
WPATH is like, the World Professional Association of Transgender Health, which I have many complex and nuanced feelings about. We don't have time to go into. They also have a directory of providers as well. And then Out Healthcare is a venture startup organization that is trying to compile a directory of affirming LGBTQ healthcare providers. So I think those are the main ones we have linked. There's also a queer and trans therapists of color directory, because one of the things we did not say in this is that accessing gender affirming care, there's so many barriers to it already. And so if you have any other intersectional, systemically undervalued identity, it becomes even more complex and complicated. So finding providers who have, again, similar lived experiences, intersectional identities can be really meaningful and impactful for your health journey and your health experience. So that's a really rad resource.
That's great.
Shameless self-promotion. Our clinic is open in 10 states and we are accepting patients. And
yes,
I'm there. We have lots of other cool providers there too. Well, I say lots. We have 3 other cool providers there.
That's lots. Hey, that's
a few. Yeah, but they're rad humans.
And in conclusion, access to gender affirming care in HRT is life-saving, and doctors like Crystal are doing incredible work. Thank you.
Yes. Bravo. Yes. Amazing research, Dr. Beardsley. A+ for you.
Wow. Thank you. Thank you.
But seriously, Dr. Beal was such a wealth of information. It really helped me to hear them talk about how it's possible to take hormones off and on, even if you have to do just like a little more screening. And it was also very validating to hear that I'm not the only one doing that. Yeah. I love this kind of crunchy, in the weeds medical episode.
Yes. I feel like one of my favorite things that Crystal talked about in this episode was this idea that you don't have to be sure, 100% sure before trying hormones, or just treating them a little bit closer to how you would Lexapro. You think you need it, you go and you get the prescription, you try it, and you see if it works or not, like trial and error.
Totally. That's so amazing, because I feel like the issue is that, you can just go to your doctor and essentially get Lexapro, but you have to jump through so many hoops to get testosterone. Like for me, I feel like it was like a fucking like 3 to 6 month process to like by the time you get that type of gender affirming care, I think you can feel a little silly if you don't fully commit to it. But like literally just like anything, like I feel like you have to see how it feels in your body. And I think that's like such an amazing model where like it just should literally be so much easier to get this thing, try it. And then you might not even like it. And therefore, you're not wasting 3 to 6 months of your time and energy.
Oh my God, totally. Yes. It's so crazy because it's so like infantilizing.
Yes.
You feel kind of like punished for, oh, did you not know yourself well enough? Are you really trans? Like there's this huge narrative of trans isn't real. Yes. You don't know yourself as well as you think you do. So then you feel like you're giving a win to some like evil voice out there.
Yes.
If you don't like it.
I think my view of it was like, oh, this is a really, really serious medication. Whereas like, I'm so curious how easy it is for cis men to get testosterone if they need it. Like I feel like
really fucking easy.
Yeah. Really like that's gender affirming care. So like, what if I just want to like try something out? But like, I think they view it as like quote unquote like unnecessary. Yeah. So it's so frustrating. But grateful that there's amazing people like Dr. Beal who are giving people life-saving access to gender-affirming care and HRT.
Totally. It was so great talking to them. And this is actually part 1 of 2 episodes where we get into the details about medically transitioning. Next time, we're going to talk to Kayla McLaughlin, who's a physician assistant and gender-affirming surgery liaison at a hospital here in LA, where we'll talk all things bottom surgery, top surgery, all trans affirming surgery. So stay tuned for that.
Gender Spiral is an original podcast from Audiation. This episode was mixed by Matt Noble, and music is composed by CMD plus Jasmine, courtesy of Molten Heart, with art by Joey Hahn and graphics by Michael Tyrone Delaney. The show is executive produced by Ireland Meacham, myself, Babette Thomas, my co-host, Allie Beardsley, and Sandy Smullins, with additional story editing from Susie Armitage.
Thank you so much to Dr. Crystal Beal. You can find their practice Queer Doc at the link in the show notes, along with some further reading about HRT and trans healthcare.
In the show notes, you can also find information about how to contact your legislators and tell them to lean on the DEA to extend telemedicine prescribing flexibilities. And we've linked to Queer Doc's directory of trans and gender-affirming resources available state by state in the U.S. If you like the show, please head over to patreon.com/genderspiralpodcast to support us. You can also check us out at genderspiralpod.com, where you'll find transcripts for each episode and a link to leave us a voicemail.
And follow us on Instagram. It's at Gender Spiral. Subscribe wherever you get your podcasts so you don't miss a new episode. They're coming out every other week.
Audiation.